We are all live now. All right. Welcome to the pulmonary module. So there are two big major chunks of this pulmonary module. One is your asthma, the other one is COPD, and then there are a couple of things like tobacco cessation and a couple of small topics here and there. We'll have, I think, probably one and two resident and adjunct to come and fill some of those lectures. But for the most part, asthma and COPD is going to be like the vital component of this particular lecture. When you talk about asthma and COPD, there is something very common in asthma and COPD. What is that? It's a disease of the lungs. So that's one of the reasons we talk about pulmonary. I'm here to basically give you some idea which you're already aware of, the lung physiology or the pulmonary physiology from your biomed lecture, which we discussed in the past. All right, so these are going to be your objectives, which you will be responsible for. I will prepare my exam questions from these three objectives only. All right. When you talk about your respiratory system anatomy, we have your upper respiratory and the lower respiratory tract. Does the slides need to get off? Yes. Where does it? Where is this one? Yeah. All right, so for your respiratory system, we have the anatomy, the upper respiratory system, and the lower respiratory system. You cannot get simpler than this. I have highlighted things in red, which you will be responsible for. Upper is basically your nose, nasal cavity, all the things which basically let you inhale the air. The lower respiratory tract is where the gas exchange really takes place. When you talk about gas exchange, we talk about oxygen and carbon dioxide. Okay, you take in oxygen, you exhale out carbon dioxide. So whatever oxygen you take in, it is basically going to go to your alveoli and then mix with your bodily fluids, and that's how your tissues basically, especially the blood, takes the oxygen to all the tissues. As I told you, probably in your biomedical workshop, oxygen is the most important entity every tissue will really need. If you don't have oxygen, the tissues are going to deprive of oxygen, the tissues will eventually die. Okay, so that's the most important aspect of gas exchange. So we really need to breathe in oxygen and breathe out carbon dioxide. So what are the regions of the body responsible? I'm not going to test you, larynx, bronchi, bronchioles. This should come very obviously. I'm not going to ask you a question where, can you tell me the components of lower? We're not doing anatomy class here. My questions will be mostly applied. Okay, I'm not going to ask you identify what is lower, identify what is upper. But what you really have to get away from the message is the upper is basically conditioning, filtering, warming up the air. The lower is your gases exchange. Everyone on the same page? Any questions? We move forward. All right, so we're talking about the lower respiratory tract. We talk about bronchi, bronchioles, right? So the bronchi and bronchioles basically are actually, if you basically look at the microscopical image, that's how it looks like. So if you can see, it's very dense or thicker and slowly thins out. What it basically means is that this cartilage, which basically gives the composure or the structure to this particular bronchioles, are slowly thinning out. So when the cartilages are thinning out, the smooth muscles are going to have more of an influence on these bronchioles. What it means is that if you write this formula, cartilage is inversely proportional to smooth muscle. Write this formula down. Cartilage is inversely proportional to your smooth muscles. So then now start dissecting that formula. If there is increase in cartilage, there is decrease in smooth muscles, and the vice versa. When there is decrease in cartilage, there is increase in smooth muscles. So let's go back to the diagram again. There is more cartilage here. This is your primary bronchioles, your secondary bronchioles, and your tertiary bronchioles. We just divided it. Where is what? I'm not going to test you again. There's no. So what you just have to understand is it starts with like a primary bronchial tree, just like a tree structure, secondary bronchioles and tertiary bronchioles. the cartilage goes down, there is going to be thinning of the cartilage and increase in the smooth muscle influence. Why do we care? We care about smooth muscles because smooth muscles are basically under the control of your sympathetic and parasympathetic system. So anything like your epinephrine, you're running on a treadmill, there is a high epinephrine, it causes bronchodilation. You basically go out and you get exposed to some kind of dander and pollen, your acetylcholine gets released, it constricts your bronchiole. So anything under the influence, because that is unconscious. Remember, your sympathetic or autonomic nervous system is involuntary in action. You don't tell your epinephrine to release, you don't tell your acetylcholine to release. It is always there as a checkpoint for them to basically get activated as and when our body needs it. Correct? So now you are out there and the whole survival of this human body is on oxygen that I take in, and I put myself in an environment where I don't have any control because epinephrine can dilate, acetylcholine can constrict. We are at the mercy of our own body's defense mechanism, which is very, very challenging. Okay? So what it basically means is that this aspect, which is basically the minutest, has a lot of smooth muscles controlling this. That way, there is going to be a lot of challenge, especially when there is some kind of sensitivity or hyperreactivity to pollen out there. And that's what will transition us into asthma tomorrow. But just for you to know that why one of you get asthma, the other person doesn't get asthma. So that's a very important question which we have to answer. It basically means that that person who got an asthma is more sensitive. His bronchioles over here are more sensitive. They are reacting to the pollen out there. They're constricting. He cannot breathe properly. Versus any other person who doesn't have asthma, his bronchioles are not hyperreactive. Or his body is not reacting to everything out there. Because there is so much of crap out there. Yes or no? But what prevents your body from interacting with that crap is your own body's mechanism. Can I see a person and tell him that he will have asthma and she will not have asthma? It's very difficult. It is all your immune cells in your body which makes the determination that will influence the neurotransmitters that will eventually influence your bronchial smooth muscles to constrict or to dilate. If it is constricted, what happens? Bronchoconstriction leads to less air to come in. The air is not like less air will go into my cells. The cells cannot take the oxygen. If the cell doesn't get oxygen, what happens? Hypoxia and all of those stuff, respiratory acidosis and stuff like that. More carbon dioxide, less oxygen. All that imbalance will start happening, lead to other complications. Okay. Very, very important thing to remember. You will have one question, if I'm not wrong, from this slide. Okay. Please remember the inverse relationship between cartilage. So increase in cartilage leads to decrease in smooth muscles and vice versa. And then you can take it from there. So we already discussed this in a bit in the last slide about bronchioles and so sympathetic and parasympathetic. This is just going to be like a refresher. Sympathetic is your fight or flight. Yes, whenever you're basically in a scope of fighting or basically a flight response, you will have your epinephrine, isoprenaline, noradrenaline, and beta-2 agonists. They all cause bronchodilation. Okay. So again, what receptors we are basically thinking about when we talk about your smooth muscles? It's beta-2. So we have one heart, two lungs. So alpha-1 is in your smooth muscles, beta-2 is in your smooth muscles of the lungs. Okay. So beta-1 is your heart, beta-2 is your lungs. That's where we basically have all of those responses. Moving forward, your parasympathetic. Acetylcholine, no-brainer. It's a rest and digest. But that's basically talking about your digestion. But we also have to understand that parasympathetic is always opposite of sympathetic. If this causes bronchodilation, what does this cause? All right. Okay. Is this constriction a good response or a bad response? It's a bad response for our body, but it is actually a good response because it is activated to prevent anything which is dangerous to me. My body identifies that. And it's like, no, we don't want to take that, whatever, carbon monoxide gas out there. It identifies that. But problem is if the carbon monoxide is what it identifies, but it also our body needs oxygen, that becomes a problem. Okay, so it's a good response, but in another way, it is something which our body really depends on the oxygen. So we still need to breathe, still need to survive. That becomes a challenge, especially with your bronchoconstriction associated with your parasympathetic tone. Things to remember here: M1 and M3 receptors. M3 is your bronchoconstriction, like in your smooth muscles. M1 is basically your receptor responsible for mucus secretion. Okay, so there is smooth muscles where M3 receptors are present. There is mucus secretion. Let me remind you guys again with your parasympathetic nervous system. In the class, we discussed about acetylcholine responsible for all the secretions. Your eye, lacrimal secretions, your nasal secretions, your GI secretions, all of the secretions. So activating an M1 receptor will cause increase in all the secretions. One of the things which we are relevant in our class today is your mucus. I can tell you how it becomes bad. Okay, mucus is nothing but like when you undergo like you get exposed to like a cold or a fever, you have a lot of mucus formation. Can you be able to breathe properly with that mucus? It's like loaded with a lot of that phlegm. It becomes so difficult. So that is a defense, but that defense will slowly make it difficult for you to breathe, and then that leads to like reversible damage of your asthma, like of your smooth muscles, leading to asthma. Moving forward, things highlighted in red is what you really need to understand. Ciliated epithelial cells, this is part of your physiology of your respiratory mucosa. They have ciliated epithelial cells. Cilia basically means those elongated hairs. Okay, they're responsible for moving any debris and mucus out of your respiratory tract. Okay, goblet or mucus glands, they're responsible for secreting mucus. And lamina propria is also known as cartilage, which is important for maintaining the whole structure. Okay, so we have ciliated epithelial cells, we have goblet cells, and then we have lamina propria. Okay, you really don't need to remember like the scientific terms like lamina propria. I'm not going to test you on that, but what you really need to understand is like the applied part of it. Okay, what they really do. Okay, go ahead.
Like do goblet cells express a lot of M3 receptors?
Goblet cells not M3 because it's mucus. M1.
M1, yeah.
Yeah, so goblet cells should have a lot of M1 receptors. The acetylcholine will act on it to cause more mucus formation. And again, the idea behind acetylcholine is rest and digest. They think that mucus is important for my digestion purposes, but irreversibly, it is making it difficult for me to breathe. It's helping one way, but it's challenging me as in a different way where my body is already having that response of hyperreactivity and hyperresponsiveness and leading to asthma-like condition. So what you really need to know from this slide, the red color, applied aspects of each of the cell, okay? Who is that? Kingsley.
M2 receptors to worry about.
Sorry?
The M2 receptors in the lungs.
M2 is not in the lungs. Where is M2? In the heart. In the heart. I mean, again, we're talking about general M2. M2 may be present in your brain as well. So we're not talking about M2 in that context. Right now, we're talking about M1 and M3 in the context of your pulmonary. So let's not go to M2. But you really need to know M2. I'm not going to ask you. So M1 and M3 for sure. Beta 2 for sure. Where is beta 2 again? In your lungs. Beta 2. Beta 2 in your lungs. They're responsible for bronchodilation. Then we have M1 receptors. M1 responsible for M1, not M3. Mucus hypersecretion. And then M3 responsible for bronchoconstriction. So there is a balance between M3 and beta 2 to constrict and dilate. They always are in balance with each other. M1 is one additional thing which is responsible for mucus. Okay? These are all important players in our body as checkpoints. You know, we have checkpoint quizzes to keep you, whether you're basically progressing in the course in a check, These are all checkpoints in your body to prevent you from the actual damage. But in that over prevention, like a mother who wants to protect the child, but overprotection leads to spoils the child. They are doing the same thing. They are overprotecting or overdoing things that leads to us creating a problem called asthma. Okay, that they produce over mucus, they produce over constriction, they produce less dilation. All of that can lead to over complication of your bronchial smooth muscles. And the only challenge with bronchial smooth muscles is that tertiary bronchial tree, which I told you. Those tertiary bronchial tree are under the control of smooth muscles, and those smooth muscles are under the control of acetylcholine and epinephrine. And whenever epinephrine and acetylcholine, they don't listen to us. They are involuntary in nature. They act based on their own thinking. They think something is danger, they're gonna start releasing. They don't ask us, let me just allow oxygen, don't allow carbon dioxide. They're gonna say there is carbon monoxide available in the gas, let me stop it. Okay, let me constrict it. All right, moving forward. Alveoli or alveolus, whenever that term comes to your mind or it looks like you see it in any kind of case study, you have to, first thing we should remember is gas exchange. Alveoli, gas exchange. Alveolus, gas exchange. They are the same. Alveoli is the plural form of alveolus. Okay, this is basically situated over here, and as you can see, this alveoli network has a lot of red color. What is this red color? They are the blood vessels. In another terms, they are called as capillary network. They carry the blood. And the capillary network, as you can see, this capillary network over here and your alveoli, they are in close synchrony with each other. The gas, which is basically oxygen, can easily get into my capillary network, and the capillary network carries the blood. It also absorbs the oxygen. Oxygen then gets disseminated to all other tissues in my body. Okay, so this capillary are lipophilic in nature. Okay, oxygen is a gas which is lipophilic. It can easily penetrate into my capillary network or the capillary layer and then move on to take the blood takes the oxygen and then it disseminates to all parts of the body. Any questions here? Okay, this is all talking about that. One of the things which you also have to remember is there are elastic fibers which control the size of the alveoli and pushes the air out. Okay, so in addition to capillaries and alveoli, there is also elastic fibers which control the size of the alveoli. What does it mean? Alveoli are like small buds, like flowers. When the flower is kind of blooming, initially how the flower looks like, it's just like small pockets of everywhere in my lungs. So this alveoli, those small buds are under the control of elastic fibers. What does elastic mean? They can stretch and they can contract. Again, these elastic fibers, let me ask you this question. If it is under the control of any of the neurotransmitter, then we are at the mercy of that. Yes or no? So we don't know the literature out there about whether it's under the control or not, but they still have elasticity, so they can increase in size or decrease in size. Increase the size of the alveoli or decrease the size of the alveoli, depending on the demand and the need. Are we good? Let's move forward. Let's do a quick knowledge check to kind of like really consolidate everything what we learned so far. Which of the following statements correctly describe the function of bronchi and bronchioles in the respiratory system? They regulate oxygen, they trap pathogens, they act as passageways, or they secrete surfactant. They act as passageway. All right, let's move forward. What is the structural difference between observed as bronchi transition into bronchioles? What does it mean? Bronchi is your primary, it gets transitioned into bronchioles, which are your tertiary bronchial tree. What really happens here? Read that carefully. Option is C. Decreased cartilage leads to increase in the smooth muscle. Okay. What is the role of beta 2 receptors in bronchioles?
C.
Bronchodilation. What is the role of elastic fibers in the alveoli? It's control the size of the alveoli. Okay. All right. So this is basically a remember question so far. As we move forward, I will have in the exam understand and apply. Okay. From the science perspective, the clinical is always your apply and analyze and evaluate a case. But for my part, we are going to up the game as we move forward. So what it means is, out of 10 questions, if I ask you in the exam, 8 would be understand and apply. We will have probably 1 or 2 as remember. Fair enough? Okay. So you will see some apply questions as we transition into next couple of slides. Okay. They're not as difficult as a clinical case, but that still lets you do some critical thinking for all the concepts we're going to learn as we move forward. All right. So coming to asthma pathophysiology, so how all of those things which we learn, we have probably understood what really happens in asthma. One of the things which we are really not aware of asthma is a reversible bronchial, whatever it's called, like a disorder or a disease. Okay, it has 2 components to it. We discussed so far about bronchoconstriction. There is also another component to it. What is it? Inflammation. Okay, it's the inflammation which is basically the biggest player in asthma than bronchoconstriction. Okay, again, when you talk about inflammation, inflammation is a response. What is inflammation? It's an immune response. Yes or no? Immune response to something which you can control?
No.
You cannot control. So someone gets an asthma, someone doesn't get an asthma. It is one of the things to explain that is not you and me which can explain it. It's basically the genetic makeup which explains it. Okay? An individual who ends up getting an asthma is because of its genetic makeup. That's how much we could explain. You and I can go out and come back from pollen exposure, but an asthmatic patient goes out and then he completely has to be taken to an ER room. As simple as that. Why? Because his body is going to release all of this. His body thinks that everything which is out there is dangerous for his body, so they will release immune cells. Immune cells get activated to release inflammatory mediators. Inflammatory mediators does what it has to do. They are like defense pathogens, defense mechanisms waiting to camouflage the pathogens or xenobiotics out there. Okay, so let's see one by one. So what are the most common affected pathways in a pulmonary system? Is your bronchi and bronchioles, as you can see. And what we have discussed so far is the hallmarks, like inflammation. Inflammation is nothing less than an immune system. So your immune system has mast cells, it has lymphocytes, it has interleukins, and it has eosinophils. There is no shortcut to it. You gotta remember all of it. It's practice, practice, practice. Okay. Remember the keywords, then you get the game. Okay. IL-5, let me help you. Whenever IL-5 comes to your mind, IL-5, remember an eosinophil. Write it down. IL-5 is equal to eosinophil. IL-4 is equal to IgE. IgE. E as in echo, IgE antibody. IL-4 is equal to IgE antibody. And then what we're left with, IL-13 is equal to mucus, hypersecretion. So far how many we read? 4, 5 and 13. These are the most important players which are going to cause inflammation. Are we good? 4, 5 and 13. Can you remember this? Because you will be asked a question. Don't complicate yourself. Everything over here is important, yes, but if you put it in a proper structure and you listen to my class it will come so easily in the exam. You complicate yourself, you read all of this, and then you get confused. Okay, so please don't do that. But again, you will be responsible for most of this for your exam. So let's break it down one by one. First and foremost, we talk about mast cells. Did we discuss pulmonary in our biomedical workshop? Did we talk about mast cells? No.
So in immunology,
In immunology, I talked about mast cells. So when you talk about mast cells, what kind of chemical mediator you talk about? Histamine. Okay, mast cells basically hold a lot of histamine inside it. So you activate a mast cell, you release the internal components to it. And what is that process called? The internal components getting released. This is called as degranulation of a mast cell. Okay, degranulation of a mast cell can release histamine, which is a primary mediator. But always remember that mast cell is not histamine only. There's a lot of misconception out there, and even I had that if mast cell is all about histamine, there is something more to it. There is leukotrienes and prostaglandins as well associated with this particular mast cell. Moving forward, T H2 lymphocytes, they release interleukins, as I told you, 4, 5, and 13. Again, what is 4 for? 4 is equal to? 5 is equal to? 13 is equal to? Mucus hypersecretion. Please remember this. It's gonna make your life easy for this particular class as well as for the exam. Interleukins, as such, they're responsible for chemotaxis. What does it mean? Chemotaxis.
like signaling, like
It's like signaling. So what really happens is when a person gets exposed to this asthma, one of the mediator, for example, interleukins get activated, it gets released here. It says like I am alone not enough to help the danger, which is basically your. Let's talk about an example of a fire extinguisher. I can't control the fire, so he calls another person from a different substation, so they come in. He calls another person from a different substation, all the fire vehicles come together. That's what happens. Interleukins first, especially the IL-5, causes eosinophil chemotaxis, which means like eosinophil get activated and it causes leukotrienes, it causes prostaglandin, it causes histamine, it causes all those other inflammatory mediators to all come, which we don't really need. But that is what my body's defense is. It's causing everyone to come together and everyone is going to do something to help. But inadvertently, it is making it difficult for us to breathe. By causing release of mucus hypersecretion, collagen formation, and all of that, as we're going to read about the asthma as we move forward. But that's what's your interleukins. And the eosinophils, as I told you, they are IL-5. They're responsible for inflammation and tissue damage. If you're going to remember any of this, remember that all of these are responsible for inflammation. You cannot go wrong there. What's generally interconnected each of them? Inflammation. So if that is the response ABCD, you have to select inflammation. But there is no inflammation and the instructor or the professor is asking something more specific, then that's when your 4, 5, 13 will help. If he's not even going there 4, 5, 13, then it basically depends on the mercy of how much you have read for the exam. Okay? Are we good? Can we move forward? When it is 1 hour, please remind me. I don't watch my time. Okay? We have to give you the break. I can't keep going.
yeah, it's 12:04.
Okay, so remind me, 12:30?
So 30.
Okay. All right. How are we feeling so far? We initially, so students who have came late, we initially started with pulmonary physiology. We talked about the first slide, talk about upper respiratory system, lower respiratory system. Please don't spend ton of time to understand what are those anatomical structures. I'm not going to ask you. I'm going to ask you the physiology. What is upper responsible for? What is lower responsible for? Upper is for conditioning, filtering, and warming. Lower is for gas exchange. We moved on. What was the next slide? Someone should clear. So we move on to basically talk about bronchial tree. We have bronchi, which get converted into bronchioles. So we have primary, secondary, and tertiary. So from between primary to tertiary, cartilage increases or decreases? Cartilage decreases, smooth muscle increases. Why do we care? Because these smooth muscles are under the control of neurotransmitters like acetylcholine or epinephrine. Then we went on to discuss about what is acetylcholine really trying to do. Acetylcholine, by acting on an M3 receptor, causes bronchoconstriction. By acting on an M1 receptor, causes mucus secretion. Epinephrine, on the other hand, acts on a beta-2 receptor of a smooth muscle to cause bronchodilation. There is always that balance between them. Then we move on to talk about the different cells in your respiratory tract. We have goblet cells for mucus, ciliated epithelial cells for prevention of any kind of virus or debris to enter into my respiratory tract, and the final one is lamina propria. It's a cartilage, basically giving a composure to your respiratory tract. And then we move on to talk about the last aspect of your respiratory pulmonary system is your alveolus. Alveoli is the plural form of alveolus. Why do we care? This is the place where the gas exchange takes place. This is the lowest part of your respiratory system, which is closely connected with your capillaries of your blood vessels, and that way there is going to be exchange of any oxygen which comes to the alveoli with the blood, and the blood takes the oxygen back to other tissues in the body. So we move on to talk about the most important aspect of asthma, why we care about the pathophysiology. We talked about bronchoconstriction. There is another component to asthma which is called as inflammation. When we talk about inflammation, we talk about all the inflammatory players out there. One of the things which we talked about are the mast cells which cause release of histamine, leukotrienes, prostaglandins, interleukins, Th2 lymphocytes. What else? Eosinophils. Yeah. They all, what is the one thing is common in all of them? They all cause inflammation. Like that's the end outcome. That inflammation can end up leading to constriction, tissue damage, and all the other good stuff. Okay? All right. We summarized it? Good enough? We are all on the same page? Okay. Moving forward, we talk about T lymphocytes, right? Well, that was one of the players. How does that really come into picture? These T lymphocytes, whenever your body, these are lymphocytes or cells in your body. Okay? Now just start imagining. You read this slide, you cannot understand. Imagine like THC cells are sitting there, the lymphocytes. What are the functions responsible for? Whenever I go out, they are going to sense what is out in the atmosphere, and they will activate this or this. CD4 TH cells or CD8 TC cells, which are basically, C stands for cytotoxic, TH is basically the knife cells. Okay, the CD4 cells. CD4 is also one of the important targets for which disease? Infectious disease. HIV. Okay, so this is very common for you and me. This is basically your defense. Okay, this is the defense where HIV is very smart. It comes and it destroys my defense. Now your body is completely under immune. Anything can come and attack you, and then you basically will end up having that disease. So since CD4 cells get differentiated into two cells, okay, the thing we have to remember is not divided, differentiated. Okay, TH1 and TH2. Forget about this for right now. Exam 1, don't worry about the right side. Worry about the left side. We come down to the right side on exam 2. Okay? Make it simple for you. Alright, so exam 1, CD4 cells get differentiated into 1 and 2, which is basically a TH1 and TH2. It has the brackets. This is an allergic response, which you and I can have. You go out, you start sneezing. What is that? It's all allergic response to anything which is not good, like dust. Someone has allergy, you start sneezing to it. That's your body's defense, which is good. Okay, so this allergic response, what really happens is your macrophages and B cells sense something which is not good for your body. It activates and it produces a response. And that is not an asthma response, just a general response, which we really want. If you are going to breathe everything in, you're putting all the bad things in your body, you eventually will going to suffocate. So this is a good response. So the other response is a Th2 response, which is an inflammatory response, which is probably something which people with asthma has it. Suppose two people are going out, one expressing Th1, one expressing Th2. Who decides who expresses what? I have both 1 and 2. He has both 1 and 2. But he overexpresses Th2, I overexpress Th1. Who will end up getting an asthma? 2. Why? But who decides? Why did I decide? Did he decide that he want to have more Th2?
No.
Who is responsible for it?
Genetics.
Your genetics. And again, that is something which you and I cannot control. So what is the therapy out there? It is like suppressing your immune system. Corticosteroids, which are out there, one of the best drugs for asthma, is suppressing your immune system because your immune system is sensing everything out there as dangerous for my body. So you suppress, so you less sense. And this response of sensing everything is called as hypersensitivity or hyper-responsivity. So asthma is a condition of hypersensitivity, sensing everything. Standing here, I start having asthma attack. Nothing is happening here, but the body doesn't understand that. So Th2 is what we really don't need. What we really need is Th1. Are we good? This is the make and break slide for all the lecture going forward. If you don't understand here, you won't understand why are we even talking about Th2. Does everyone agree that Th2 is a troublemaker here? If someone has hyper activation of a Th2, will end up having asthma because of all the things which will happen, like inflammation and all of that. Okay? So they trigger inflammatory cytokines and generate an asthma response. Are we good? So we're building on that again. Okay? We're building on your Th2. You see that? Th2. Now I'll not go back and explain what is Th2. We understand where Th2 is coming from. Okay? Your body, again, this is your respiratory tract, your airway, and this is allergen. Allergen is anything out there in the air. Your body gets exposed to it. It brings to your cells in the body, which are basically your knife T cells. And these knife T cells can go two ways. One, the Th1 route. The other one is the Th2 route. Th1 is this route. What does it do? It activates macrophages, some of the cells, like very, very minuscule. And it basically, what is macrophage responsible for? For phagocytosis. If phagocytosis, that xenobiotic or whatever allergen, everything is back at peace. What happens to your bronchia? They're wide, they're open, nothing is happening to your mucosal glands, everyone is at peace, no asthma whatsoever. This is all under the control of Th1, which you and all, I don't know how many people who end up who has asthma in this room, but I'm giving an example that any normal person should have Th1. One of the good things you have to remember, which Th1 also does, it releases interferon gamma over here. You see that highlighted one? What does it do? This interferon gamma can go and stop the Th2 response. It's increasing Th1 and it's also stopping Th2. Because I cannot decide that they should be Th1 or Th2. My body itself decides. But what I can also do is inhibit the Th2 response. That way I don't end up getting an asthma. All good? Let's talk about the Th2 response. People who end up getting asthmatic. So again, we go back to the ground zero. The allergen get exposed to my T cells. I can go two ways, right? Th1 is the normal people. The Th2 are the asthmatic people. So if at all their body brings the allergen to a Th2 cell or activates that, these Th2 cells will do all of this. Let's go one by one. These Th2 lymphocytes are going to cause the release of 4, 5, 10, 9, 13. Okay? I have written over here. IL-5 is eosinophils. IL-4 is B cells or Ig antibodies. IL-13 is your mucus. That's where I got the answer from. Okay? So all of this is what it's going to cause and release to cause increased hyperresponsiveness. And what it's really going to do is it's going to completely change the physiology or the structure of your lumen of your airways. So what's happening to the lumen? The space is getting smaller. The cells are going to get changed. You see those cells here versus this cells here. They look more thicker. If you maximize it, you can see the difference. They're more thicker. The more thicker basically means they don't respond as it has to respond. They becomes like whenever the skin goes off, like if you fall down, you get a bruise, a new skin comes on top. Is that skin the same as your old skin? What is the difference? It's more thicker and more fibrous in it. That's what really happened. There's tissue damage because of those inflammatory cytokines, and it causes new tissue to come in. They become more fibrous, and that's one of the conditions of pulmonary fibrosis, what you call it. They don't respond, they don't contract, they don't dilate as and when it's required to dilate. They make it more difficult for you to breathe eventually. Lead to bronchoconstriction, and this bronchoconstriction doesn't happen first. What happened first? What happened first? Inflammation, which leads to bronchoconstriction. So what is the hierarchy? It's not constriction which starts first. It's basically your inflammation, which then leads to constriction. If we have to help the patient, what are we going to do? We're going to reduce his inflammation and reduce his constriction. Bronchodilators and anti-inflammatory agents. Are we good? This is an example of all the IL-4, 5, and 13. Please don't spend a ton of time reading this, okay? What you just have to remember is IL-5 is equal to eosinophils, IL-4 is equal to Ig antibodies, and IL-13 is equal to mucus hypersecretion. Like that's the functionality, okay? All of this stuff is good. If you're not hearing my slide today, you're basically losing on it. People on, there's no Zoom, but who are going to hear this later, please don't spend time. It's not worth it. Let's do a quick knowledge check. Which immune cell subtype is most commonly associated with triggering asthma-related cytokine release? That is 4, 5, and 13. Th2 cells. Okay. Which cytokine is primarily responsible for recruitment of eosinophils? 5. 4 and 13 have different functions, right? What is 4 for? 13 for mucus. What is interferon gamma? Remember we saw that? Stop the Th2 response. Good. A patient with asthma shows chronic airway inflammation and mucus hypersecretion. Mucus, what comes to your mind? Which IL? IL-13. All right, that's all I had on that. Where are we with the time? I'll take like 5 minutes break.
Yes.
Just go around, walk, come back, and then we'll get
Tengo que ponerme la mejor, tengo que ponerme la ella quiere que le diga eso, igual que le digo con tu nombre, que está interesado, que vaya a saber. El día que lo vamos a repetir, el día de la me dijeron que nos faltaban matemáticas. Nos faltaban para examen de matemáticas. Antes de la para
Where's your mark? Ajá.
Está bien vivo ahí.
Yo vivo ahí.
Está bueno, ya.
Yo vivo
Dale,
muy
dale.
bien. So, yeah.
Sí, yo voy a separar ahí a Tiel y yo hablando.
I've been that way.
Entonces también el transmission. Tienes que enviar el transmission como ficha, ¿no? Y ahí tiene todo el
Ya la
pago
transcripción de crédito.
y no se paga el
No tenía que pagar el pago. Muy
Bueno, sí, lo voy a.
Bueno, hay que instalar como ficha. Le digo, voy a instalar como ficha.
Hay que preguntarle eso.
Cuando en el apartamento, cuando me estudiante me pidieron el translation, yo le digo como ficha. Me dijeron, ay, yo pero como ficha, yo que no te pongo como ficha, pero yo no te quiero.
¿Y para qué ella quiere eso?
No sé, a ver qué mundo está en mi cabeza. En que, como que, cómo tú estás. Y en que ella lo tuvo, que ella
Vamos a checar eso.
No sé. De verdad que no me.
Eso es para que la
Mucho.
Yo no voy a mandar la conversation. Si ella me pide la oficina.
I think,
Oh, I have not yet looked at the timing of Yeah, I was in the email and I was like, what is? And I was like, That was about like. Yeah, I'm like, don't go to this. Then I come in, I see that. Yeah.
Lower cancer.
Yes.
What do you think they're gonna post a grade? Please.
Abigail, I'm trying to talk to the site. There's a lot going on the site. The first thing I get to talk to the other person. I have to talk to the director, so they're not responding. Yeah, you moved the topic, but you might have to do it in May, like May 3rd, like right before. Yeah, right before. Like May 3rd or 4th, like the weekend before class event. I know, it's rough, but I've been trying to like, get us to be like food service. But we'll see, I'll talk to you guys when I figure it out.
No, it's just,
How long was it?
yeah, sure, yes. And I will be like, oh, yeah, this one one for hypertension. So, and I sent this people that I sent is for hypertension.
Vamos a ir a comer, pero no, pero no buscarlo en el pasaporte. Si lo van a llegar acá. Deja ahí todo, porque Alex, no tengo que
Okay. Yeah. We have pension is diabetes.
Yeah, it should have been due today, but yeah. So I'll send her email like, okay.
I see her email.
I'll do it. I will do the ratio and since it's 20 topics, it's gonna be like 3 point something, so someone might be like 4 topics or I don't mind because So everything in one slide. Everything. Like for example, medication management, stress management. Okay, here for a second. Okay, I'll send it in the chat just because just to let them. Okay, thank you, Doctor.
The one that discovers it, like, something again. Send it to us. I don't even know what he did.
All right, guys, let's get back. Probably should not take more than 30, 40 minutes from here, but let's see how we can. If you're following everything what we have done so far, I'm not teaching you anything new. This is all I'm building on those things. All right, so we discussed about in the last slide the TH1 versus TH2. TH1 is like leads to an allergic response, which is normal. Resident macrophages get active, dephagocytize the allergen, everything is at peace. No inflammation, no all those exaggerated response to the bronchioles. Everything is normally a person is breathing. When it comes to TH2, which is mostly genetic mediated, a person who gets TH2 activation ends up leading to release a lot of those inflammatory mediators like IL-4, 5, 13, histamines, prostaglandins, leukotrienes, and all of that together, creating a cascade of inflammation, leading to hyperresponsiveness and hyperreactivity, and finally causing those mucous hypersecretion, the lumen of the air gets shrinked, there's constriction associated with it, a person cannot breathe properly, and end up needing medications to help him get through that stage. So this is a similar diagram where we talk about what happens imminently and what happens over a period of time. Because asthma is not like a fever, which happens like for a week and everything is back to normal. Asthma is a disease which is a chronic disease, which a patient or a person lives with it because its genetic buildup makes him vulnerable to that particular disease. So again, this diagram is not new. We are looking at acute and chronic response. Acutely, when a person who is asthmatic, okay, so we're talking about asthmatic patient. So which lymphocyte we're talking about here? 1 or 2? So what is it here? TH2, yes or no? Okay, and an acute person, we forget about TH1. No more TH1. TH2 is hyper responsive and TH2 is hyperactivated. So this allergen gets into his respiratory tract, and this respiratory tract presents it to a TH2 cell. The TH2 cell basically is your immune cell. This TH2 cell, which is an immune cell, will cause release of all these inflammatory mediators. Yes or no? So we have 4 and 13, we have IL-9, we have neutrophils, we have IL-16, and all of that. So this 4 and 13 will end up going to a plasma cell to cause formation of antibodies called as IgE. Yes? So antigen, for every antigen there is an antibody. Yes or no? So for the first test, which probably Dr. Macaulay would talk to you when you do an allergic response or even asthmatic response, is identifying your IgE levels. So people who have allergy, like I had allergy, not an asthmatic allergy, just like an allergy. The first thing what doctor do is draw blood and find out where my IgE levels should be. I will always have elevated IgEs whenever I have that pollen, like during that time. It's because of my allergic response is higher. So these Ig antibodies are going to get activated. So for this antigen, Ig is formed. This Ig has an ability to go to your mast cell and go and bind to the receptors on the mast cell. Okay, so this mast cell has IgE bound to it. What is this IgE for? This is an antibody for the antigen. Can I tell that antibody for an allergen? Is that the same? Antibody for an antigen versus antibody for an allergen. For simplistic purposes, I will denote antigen or allergen as the same. So this antibody is for the allergen. Yes? So your antibody basically sitting on this mast cell and waiting for the next time a person gets exposed to the same allergen. So you go out again. Your body has already identified antibodies and it has prepared and it is waiting on a mast cell. As soon as your body sends the same antigen again, not antigen, allergen again, what does it do? These allergens come and bind over here. You see that? They come and bind. This binding of an allergen with an antibody will activate the mast cell. Mast cell as such is not doing anything. It is at peace, normal. But as soon as the Ig antibodies is sitting here and the new second time, this is the second time exposure, not the first time exposure. What happens with the first time exposure? Generates IgE. The second time exposure, this IgE goes and binds to the receptor where it has to bind, basically the mast cell, and binds to this allergen. Second time comes and exposes to this antibody. You can see that this causes activation of mast cell. So write down activation of mast cell is equal to degranulation. The mast cell by itself doesn't do anything. It has to get activated. And who activates it? The IgE bound to an allergen in the brackets, second exposure, not the first exposure. For the first exposure, your body is just making antibody. The second exposure, your body is now activating a mast cell to release. Why are we all talking about this? We're talking about this because we are concerned about this mast cell cause release of which mediator? Histamine. 90% of the times it's histamine, but it can also release other mediators like leukotrienes, pleasure activating factor. They all are going to cause acute asthmatic response. Immediately, this is what we'll expect to happen. Acute response. If this is uncontrolled, person is not controlling this with medications and so on and so forth, it will end up becoming chronic. And in the chronic, we have more better players which are coming at the rescue. And the players which are coming to the rescue are the leukotrienes. And leukotriene, the way it tells in your textbook, I think one of the leukotriene, again go back to the textbook, don't quote me on that, is 1,000 times more potent than an histamine. A leukotriene power, imagine like it's an extinguisher. It's an extinguisher which has 1,000 times more power than a normal extinguisher. And what is histamine responsible for? Constriction. If you release leukotriene, it is going to cause 1,000 times more constriction. So you just let it go. You know, I don't care if I'm not breathing, things will normalize, my body is going to adopt. No, this is a genetic problem. You're going to need medications to help your body. Acute transitions to chronic in no time, and now we have more inflammatory mediators which are coming and kind of making it more havoc in your pulmonary system, which can lead to basically completely not be able to breathe properly. And here we have all those airway remodeling. So that's one of the aspects of chronic versus acute is over a period of time your whole airway gets remodeled. And open the bracket here and write down. Open bracket here and write down. Subepithelial fibrosis. What does airway remodeling mean? Subepithelial fibrosis. Mucus hypersecretion, comma, mucus hypersecretion. Hypertrophy and hyperplasia. Hypertrophy and hyperplasia of smooth muscles. Hypertrophy and hyperplasia of smooth muscles. So what has happened so far? A person who is not controlling his asthma in an acute phase will end up becoming chronic asthmatic. And in chronic asthmatic, one of the important things which we have to worry about is the leukotrienes, which are more potent, 1,000 times more potent than an actual histamine. And then all of those really still keep happening. We have interleukins, we have prostaglandins, we have histamine, we have platelet activating factor, we have all those inflammatory mediators plus a leukotriene. Imagine like leukotriene by itself is so potent, plus our body has to deal with all these other inflammatory markers. this will all come together and completely change the whole airway to remodel it to cause more difficulty to breathe. And that is your chronic phase of inflammation. Here we have all those things which I've already talked about, just for your reference. Any questions? Let's do a quick knowledge check. Which of the following events is characteristic of an acute asthma? Th2 activation, mast cell degranulation, airway remodeling, or eosinophilisis? Characteristic of an acute asthma. Th2 activation happens whether it's an acute or a chronic. So it's just not acute. Okay, airway remodeling is what? Chronic, acute. Eosinophilisis is basically increase in eosinophils. A hyper increase in eosinophils. Again, that's a chronic. So what is left? What is the primary function of histamine and leukotrienes released during allergen exposure in asthma? Histamine and leukotrienes. Histamine responsible for causing bronchoconstriction. Okay, as I told you, histamine and leukotrienes, what is the common thing among them is they both are causing constriction. This is 1 time, this is 1,000 times. Okay. Which process is characteristic of chronic asthma? All right, so it's airway remodeling. And finally, which of the following cell types is primarily responsible for producing IL-5 and recruiting eosinophils in chronic asthma? Which of the following cell types will recruit IL-5 and eosinophils? Th1, we're talking about asthma, so we're not talking about one anymore. It's Th2. All our macrophage and neutrophil, they are not responsible for, so it's basically your Th2 cells, which are responsible for recruitment of eosinophils and IL-5. Are we good? All right. So the same acute and chronic response is again now divided into like a flow chart. Okay, if you couldn't follow that in the diagrammatic representation, then I have like a flow chart. What really happens? Let's talk through this step by step. The immediate and acute response to any kind of allergen, right after contact with allergen, rapid activation of IgE release causes mast cell to activate. Yes or no? The release of pro-inflammatory mediators like histamine and leukotrienes, to some extent, an acute asthmatic reaction leads to all this: mucus formation, vasodilation, bronchoconstriction, and activation of B cells and T cells. It's not that it's not happening in chronic, in acute, it started happening, but in chronic, it happens more for a longer time with additional players getting involved. So a few hours after allergen provocation, it starts with an activation of Th2 cells. In addition to histamine, we have leukotrienes, which are the most important bronchoconstrictors in late phase. And there is also increase in levels of eosinophils, basophils, IL-5. They're all what? They're all inflammatory mediators. It's more difficult to reverse and more severe and prolonged reaction. Okay. So we have probably, I don't know why I have a knowledge check here again. So which cellular response or which cellular process characterizes the acute response phase of asthma? Acute. What distinguishes chronic from acute? What distinguishes chronic from acute? There's only one answer which stands out.
Like airway remodeling.
But this one, there's no airway remodeling here.
Okay, I thought you asked an engineer.
It's gonna reduce it.
What about Th1 cells? Why are we even talking about it? What about decrease release? Does it decrease or does it increase? What about absence of eosinophil recruitment? Why will absence? Because we are talking about everything coming to rescue it. So there's increase. Acute is like a small when it starts happening. Chronic is like everything is coming together and it's happening together. So this increased production of histamine and leukotrienes is what happens in a chronic stage compared to acute. Following allergen exposure, a patient experiences wheezing and bronchospasm. Which event likely occurred first? Think about it. Bronchospasm. There is an acute response and there is a chronic response to it as well. I mean, this question is kind of confusing for me as well. So let's talk about one by one. Forget about the answer to it. We'll get to the answer, but I'm not satisfied. This is me like really preparing this handout late in the night. So, following allergen exposure, a patient experiences wheezing and bronchospasm, which event likely occurred first. We talk about basement membrane thickening and airway remodeling. What are these C and D? Is it acute or chronic? Okay. Alpha and mast cell decranulation. Acute. So we have an acute response and we have a chronic response. We don't really know what has occurred first. Okay. So at this time, but what we just really have to understand is which is acute and which is chronic. Just highlight that and take out the response completely. Okay. And remove this thing from here. Which event likely occurred first? We don't know the answer to it. All right.
So what do you want to do? It's not the answer.
The answer is not airway remodeling over there. Okay. I want you to understand that C and D is your chronic, A and B is your acute response. Okay. Please remove airway remodeling from there. Which physiological effect is direct consequence of IL-13 overproduction? IL-13 is mucus. You cannot go wrong there. Okay. Anything which is associated with mucus is what you have to remember. All right. So again, if you have to understand what is your acute is basically all the things happening on the right. Chronic is what? All the things happening on the left? Are you sure? Or it's everything? It's everything.
Chronic is everything, acute plus.
Acute plus all of it. That's the reason this red circle is basically a chronic. You got it? All right. It's probably last plus now. Like this one more slide after this, and then we are probably done. We discussed this already. Airway remodeling is one of the characteristic feature of your bronchial asthma condition. There are three important components to your airway remodeling. One is subepithelial fibrosis. What does it really mean? Thickening of the basement membrane. Okay, if you can see this one, compared to those layers over here, this is more thickened because of increased collagen formation. The second aspect is hyperplasia. More mucus cells. More mucus cells lead to more mucus to form. More mucus to form basically means it's clogging the space where it needs for us to breathe. Okay, so more mucus getting secreted. It causes a mucus plug formation. And finally, hypertrophy and hyperplasia, which we discussed, right, in the last slide. Hypertrophy and hyperplasia of your smooth muscles. So your smooth muscles, if they are increasing in size and number, what is happening? New cells will be replacing the old cells. These cells will be more thicker, more fibrous, more reluctant to any kind of bronchodilation or constriction. Becomes a challenge for you to for cells to basically adopt to the actual physiology. These three things. Okay, if you cannot remember any of it, please remember the things highlighted in yellow. This is nothing but they are the characteristic feature of airway remodeling seen in a bronchial asthma condition. Subepithelial fibrosis, mucus hypersecretion, and bronchoconstriction. And remodeling is irreversible. Okay, you cannot reverse it. As much as we understand asthma is reversible compared to COPD, but again, if we end up getting an asthma to an irreversible stage where like it's an end stage of that patient, it is irreversible. And the hallmark features, as you mentioned, thicker basement membrane, higher number of mucous goblet cells, and narrow airway lumen. So this diagram we have seen in the last slide. So as you can see, compared to a normal airway, the asthmatic airway has more mucous cells, more goblet cells, more smooth muscles which are increase in size, increase in number, and probably more collagen formed over here, so it becomes more thickened. Keep that in mind. So we're talking about the same pathway. So this picture will keep coming again and again tomorrow and all the asthma lectures, because I'm forming this basis of all the drugs which I can explain here, because this is basically their whole pulmonary airway wall and lumen. Okay, so this is your lumen, which has your epithelia. This is ciliated, right? So we have your membrane, and then we have your airway wall. This airway wall basically will have bronchial smooth muscles and some of the other things which are really happening. So again, we go back to ground zero. Whenever a body gets exposed to an allergen, what happens? Whenever a body gets exposed to an allergen, it goes to your Th2. So these Th2 cells basically they come and activate all of the other cells in the body, like cytokines and chemokines, Th2 cells, mast cells, macrophages, and eosinophils. All of them are going to cause release of this all inflammatory mediators. What are this? Leukotrienes, prostaglandins, pure intestine, proteases, platelet activating factor, protons. The list is never ending. This is all what we could characterize so far. For a normal allergic response, we just need a macrophage. It comes, it phagocytoses, everything is at peace. But this is a hyperimmune response to anything. Hyperimmune response causing hyper release of all these inflammatory mediators, and these inflammatory mediators can go and do all this as airway remodeling. So talking about airway remodeling, the first thing it does is increase in the number of cells. It causes bronchoconstriction, bronchial hyperreactivity, vasodilation, and angiogenesis. What is vasodilation? It dilates the blood vessels. So whatever blood vessels have, what does blood vessels have right now? The blood, but the blood has what? Inflammatory mediators. This inflammatory mediator slowly gets released into your systemic circulation. Sorry. So there is some kind of like animation on it. So this vasodilation causes release of this blood into your systemic circulation. It causes angiogenesis. More new cells are going to get formed, and more cells basically means more difficult, because they're going to be mucus cells, goblet cells, and all the epithelial cells and new collagen cells. They all make it more difficult and thickening of the basement membrane. So we have subepithelial fibrosis, epithelial shedding, more mucus cells cause mucus plugging. So all of those things really going to happen. I have explained the whole process, but here we have in words, histamine always causes vasodilation and plasma leakage leads to angiogenesis, excess of mucus leads to mucus gland hyperplasia, increase in collagen leads to subepithelial fibrosis. There is no shortcut to this. You've got to remember this. Because if you don't remember this, what is collagen? How does collagen associate? Because you will have questions where you have to understand what does goblet cells do and how they are different from subepithelial fibrosis. Goblet cells produce this mucus. Collagen formation leads to subepithelial fibrosis. They are two different. Vasodilation leads to angiogenesis. Histamine leads to bronchoconstriction. If all of those things really happen, it leads to constriction, inflammation, and airway remodeling.
Leads to chronic inflammation or inflammation.
What is it?
This is chronic or acute.
This is a chronic stage. Airway remodeling, whenever the word airway remodeling, that means it's chronic. Got it? I think this probably are the last of the knowledge checks. Let's see, histamine effects on bronchoconstriction, vasodilation, and plasma leakage are primarily mediated by activation of which receptors? H1, beta, muscarinic, and H2. GI is over. GI module.
H1?
GI module is over or no?
Yeah.
Yes.
Yeah.
That's the reason you are able to answer this. So why I'm asking GI? Because
Yeah, H2 is
H2 is in your GI tract, okay, responsible for acid secretion. So we have H1 receptors which are mediating all this bronchoconstriction. Okay, the answer should be histamine 1. Which process is responsible for subepithelial fibrosis? Remember, is it mucus or is it collagen? It's collagen. A patient with chronic asthma, with subepithelial fibrosis and increased smooth muscle mass in the bronchi, what does this all indicate? All this indicate as airway remodeling. In asthmatic patient, which action would most effective reduce bronchoconstriction? This is now pharmacology. So how can we help the patient who is having bronchoconstriction? Can we stimulate his M1 receptors? What will happen if you stimulate an M1?
More
M1 versus M3. M3 is
muscles.
M1 is, so you stimulate M1. What are we doing? More? Are we helping the patient or are we making it worse? So are we going to use that drug? Okay, let's move next. Blocking IL-4 production. IL-4 will help you with bronchoconstriction. IL-4 is an interleukin responsible for mucus. Okay, it's nothing to do with constriction, not directly due to constriction. Inhibit goblet cell proliferation. What is this? Muscarinic receptor antagonist. It's not the first line, but it's the only one on this, so we will select it. So what's your first line for a patient who is having asthma? Beta 2 agonist, okay, which we will talk tomorrow in the class, but right now it's administration of muscarinic receptor antagonist. I guess this is one of the last slides, sorry. We just do the knowledge check and we finish the class. My question is probably now you understand this is kind of like more of like a case, understand and apply. A researcher observes increased angiogenesis in the airway walls of asthmatic patient. This is most likely result of which pathophysiological event? Angiogenesis is associated with vasodilation and plasma leakage.
Back to the previous question.
This one?
Yeah, it's A, right?
Yeah.
Yes.
So I forgot to say, some of the students have downloaded the PowerPoint yesterday. I've just updated it at 12 o'clock or 1 o'clock today afternoon. Okay, so if you have not, please download the latest version. Okay, because I think what happened is I was using those circles versus those rectangles. Those circles sometimes are changing when you open the slide again. So it's moving from A to B, and then you get confused. So then I just completely discarded that oval shape and I just started using rectangles. Which change in airway tissue is most likely due to increased collagen? Collagen, what comes to your mind? Which change? Fibrosis. In patient with chronic asthma, hyperplasia is observed in bronchial mucosa. What pathophysiological mechanism best explains this? Gland hyperplasia. Mucous gland hyperplasia is mucus hypersecretion over time. And finally, a patient with asthma shows signs of airway narrowing and difficulty in exhaling. Which mediator is most likely responsible for this constriction? Bronchoconstriction. Constriction. Does collagen does anything to constriction? Third, IgE. So you gotta understand the question is a lot. And you know how you can get confused now that you know so much about it? Read the question carefully. Ask me in the exam what it is, if at all you're getting confused. Like, are you talking about subepithelial fibrosis versus something else? So here we are talking about bronchoconstriction. So we're talking about histamine. Remove collagen. I don't know why is it here. Okay. Which mediator is most likely responsible for constriction? It should be histamine. Histamine. Okay. Everyone, answer should be histamine. I don't know why it is changing when we open the slide. All right, guys, thank you.